I'm going to talk to you in the next 20 minutes on young myocardial infarction and the current status of how you treat these patients who are typically different from the typical myocardial infarction that you see. So the first question, is it different? Young myocardial infarction, the pathogenesis, the clinical presentation, the management, their outcomes, and what you do about their secondary prevention. So the first question is, what is young myocardial infarction? So by definition, there are various definitions in literature, in multiple journals. But in general, if you look at many of the definitions which are in multiple journals, it generally says less than 45 years of age. And this is very important because the traditional young myocardial infarction spoken to by the Western literature typically talks about familial combined hyperlipidemia as the primary cause for these myocardial infarctions, which are not so in India. So various definitions, but I'm going to take the definition of less than 45 years as the definitions for diagnosing young myocardial infarction. Now, the next issue is, once you've defined that what is young myocardial infarction, then what is the epidemiology? Unfortunately, the data is limited. Now, if you look at in the UK, 0.5% of men and 0.2% of women aged between 35 and 44 years of age have myocardial infarction. And in general, all myocardial infarctions, if you put about 3% of patients, will have young myocardial infarction. Similarly, in the Framingham study, you have a very low incidence of young myocardial infarction, both in men and women. And the incidence of MI in the age which is usual, that is 55 and 64, is about 8 to 10 times greater in men and women. So basically, young myocardial infarction is less common and all over the world. And in most countries, especially in the Western world, is on the lower number, about 4%. And in India, many of the studies had represented data which was published in small groups, in small journals, as about 10%. So in our typical practice of myocardial infarction, the data suggested about 10% of your patients in a country like India had MI whose age was less than 45 years of age. Now, what is the pathogenesis? So there are various causes of myocardial infarction. That is very important for us to understand because the pathogenesis is different from what you see in the elderly myocardial infarction. Yes, you can have atheromatous coronary artery disease, but you also have non-atheromatous coronary artery disease and hypercoagulable states. And this is very important because your treatment could be completely different and not the classical treatment of STEMI, which is basically an angioplasty in many of the scenarios. So if I divide the causes for atheromatous coronary artery disease, non-atheromatous coronary artery disease, and hypercoagulable states as three different groups, you can see on atheromatous coronary artery disease, the commonest cause is cigarette smoking. Smoking could be either coming from cigarettes or also could be due to urban pollution. Familial history of CAD, which is not very common in India, but is common in Western groups, is about 40%, which is caused due to lipid abnormalities, diabetes, and obesity. And sometimes acute symptomatic rises can cause this problem and cause a rupture of the plaque and create atheromatous coronary artery disease. If you look at non-atheromatous, that means no plaque. The causes can be congenital, can be muscle bridge, can be dissection of the coronaries, which happens especially in young women in the peripartum, could be embolization of septic vegetations or clots, can be aneurysms of coronary like the Kawasaki's disease, can be drug abuse. It is also not very uncommon in India to have a drug abuse now, and cocaine is not a typical Western phenomena. I had two young boys with myocardial infarction, 20 and 21 years of age, both during a rave party with cocaine in India, in Tamil Nadu, in Chennai, having a problem. So you have to be very careful when you see young patients that you don't miss this out. hypercoagulable states because of antiphospholipid antibodies, lupus, factor V Leiden mutations, and in young women of contraceptive usage can cause hypercoagulability, and with normal coronaries can present with a young myocardial infarction. So when you start looking at young myocardial infarction, be a little broad in your way of looking and don't think it's only coronary artery disease. Now, the classic presentation, which is in coronary artery disease usual, is a worsening of angina and MI is never seen in young MI. In young MI, the first episode is usually the myocardial infarction. Some of these patients may give you a short duration of less than a week. The diagnostic criteria is exactly the same as older STEMI, which basically is ST elevation with abnormal Q waves. They also can represent in non-STEMI fashion with ST depression and T wave inversion. Cardiac troponin is usually high, and you can have false positive CKs and cocaine abuse. Keep in mind when a young person comes with a young MI that you can have pericarditis and pulmonary embolism as mimics for STEMI. And you also always have to keep a watch because these two conditions will also cause chest pain with STT changes and may mimic a non-ST elevation MI. As I said, apart from smoking, a clear questioning of the patient and his relatives for drug abuse, especially when extremely young people come to you, is important. You can look for dyslipidemia, but it's very unusual in an Indian scenario to see this presentation of dyslipidemia. Now I'm going to present our work. This was published in the JAMA of the Tamil Nadu STEMI program, which was published in 2016, of a systematic, myself and Thomas Alexander published this in the JAMA, of a systematic study of STEMI over 4 hubs and 30 spokes in Tamil Nadu in patients with ST elevation MI who were 20 years and above, who presented with ST elevation in a hub and spoke model in Tamil Nadu over a period of 2 years between 2012 to 2013, and the data was collected in 2014, and we looked at the 1-year outcome of a group of 2,420 STEMI patients who were studied sequentially over 1 month, 6 months, and 1 year. And the data I'm presenting to you is a subset of that group of patients of STEMI, which is published in the JAMA, who were young. Now, out of the 2,420 patients who were of STEMI in this whole program over a year and a half, what we found that, interestingly, there was a group of patients who were less than 45, was 591. That means a 24% group of patients of STEMI were young. And this has completely never been reported of this high incidence of STEMI in young group of patients. And if you look at them, the young STEMIs were typically male. They were not diabetic. In fact, the people who were more than 45 were most likely to be diabetic. Hypertension was lower. It was more in the elderly people. And what is really important was there was a higher incidence of smoking, 57 versus 35%. P-values were significant in this group of patients. So clearly, the young patients of STEMI presented as males with less diabetes, less hypertension, and more smoking. That was a clinical scenario of these patients. Now, if you looked at the men versus the women who were less than 45, what you can see that the ages were similar. But again, what was interesting is the women had more diabetes and hypertension when they were less than 45 as compared to the men. And smoking obviously was exclusively in Tamil Nadu a male prerogative. So clearly the traditional risk factors continued to be the risk factors in young women, but in men it was overridden by smoking, which was the most important risk factor in young men. Now, if you look at the time that patients required to come after chest pain between the young patients and the old patients, you can see that the patients who are younger, their time from onset of chest pain to first medical contact was slightly lower. P-value is not significant. But what was significant was the total ischemic time. That is the time from pain onset to treatment. As the younger people got treatment faster than the older people. And this is basically related to two things. One is that patients come quickly with pain, and they have, because they have an occlusive anterior wall MI usually, they have no collaterals, so they come quicker to the hospital with just discomfort. The other process measures, which is like door to balloon time, time to fibrinolysis, between the two groups of patients, in men and women below the less than 45, you can see though the times were sort of showing that it was a little more in women, the p-values were not significant, maybe because the number of patients was lower, clearly showed that the tendency for women who are less than 45 to present are later. And this is typically for women all over the world, that women tend to underplay their symptoms, especially when they're younger. They are taught to have possibly costochondritis or gastritis, and they delay treatment. And the reasons are the usual all over the world in women versus men. And this is true also for the young women as compared to the young men. Now, what is interesting is the angiographic features. You can see that as compared to the older people with STEMI, the young patients have single vessel disease, and they have one vessel only involved, as compared to multi-vessel disease in the older people. And this is typical because these patients are more diabetic and hypertensive, so they will have multi-vessel disease. The involvement of the single vessel is usually the left anterior descending artery. And you can see that LAD is a very common vessel. The main vessel which supplies the heart is more common. The thrombus grades are higher in younger people as compared to older people. And what is the most important thing is that the younger patients, they do better than the older people. Their mortality, the chance of dying in hospital, is lower as compared to older people. Their 1 month mortality is lower, and their 1 year mortality is also lower. So younger patients generally do better than older patients in terms of myocardial infarction. And that could be, one, because their comorbidities like diabetes and hypertension are lesser. They have more single vessel disease and not multi-vessel disease, and they approach a hospital faster. Again, the in-hospital MACE events are also tending towards better for the less than 45 as compared to the more than 45 years of age. Now, if you look at the men versus women, you can see it is the women fare worse. And this is again true as usual in even older MIs, that women fare worse than young. But in young MI, both between women and men, you can see clearly that the number of patients who have are clearly showing a bigger problem when you have women as the predicting patients. Now, let me give you a few examples. This is a typical patient, a 32-year-old IT professional. He's a smoker, he's hypertensive, he's obese, a typical couch potato gentleman, no previous history of chest pain. He had just 1 hour of chest discomfort. He presented to our emergency room, and the EKG shows a typical hyperacute ST elevation anterior wall MI, and you take the patient for an angiogram. And for people who have seen the angiogram, you can see that the main vessel, the LAD, is abruptly closed here. It's a totally occluded LAD. This is a typical point where the young MIs present. It was balloon dilated, and you can see there's a lot of clot, and this is very important. These patients will have a lot of clot, and I'll tell you why that is important, because the treatment of these patients may not be requiring a stent in many of these patients, and I'll tell you why. We have some work on this now happening, because these patients have something called as plaque erosion and not plaque rupture. That means the endothelium just denudes, and you have a clot forming suddenly, and all you need is a quick anti-clotting medicine or a suction, and removal of the clot, and that's all what you need. So what we did in this patient, we did nothing. We just suctioned the clot out, and you can see that the ECG just settled with suction. We did not put any stent in this patient, and we can see that we took an angiogram at 24 hours, and it shows that the artery is okay, the flows are good. In fact, putting a stent in these patients may create a bit of harm, because all that clot may go down and create a low flow in the distal vessels and create problems. So all we did was just medically suctioned and treated this patient. And this is 1 month later, and you can see that the angiogram is showing that the vessel is still very good. There is no problem. And you can see clearly that the vessel looks very nice and pristine just with medical treatment, with a suction and medicines, dual antiplatelet therapy and statins. So clearly this is a nice looking vessel. And what we do in these patients is 1 month later, we do an OCT. An OCT is like an endoscope inside the coronaries. And it shows you clearly that the vessel is clear. It is not having a big cavity or a rupture plaque, which is normally seen in a plaque rupture. All you see is a clean endothelium with a little bit of organized thrombus. And this is the typical scenario of a recovering plaque erosion. So there is some data now to suggest that, in fact, many of these patients don't require stents. And if you put stents in these patients, you may create sometimes more harm than otherwise. This is another case, 32 years old, smoker again, anterior wall MI, came in with chest pain and sweating. And again, we can just show you the same thing, a lot of clot, and you can see the clot hanging here. This is the clot. This is irregular stuff inside the coronaries. There's all sorts of clot. It's all over the place. And what you need to do in this situation is to not put a stent immediately, because which is what normally you do, is to suction and clean the vessel up first. And after you suction and clean the vessels up and remove all the clot, then you may stent the artery if the vessel lumen is not good. So we put a stent and the vessel looks good now. And so you have to clean up the vessel and remove the thrombus before you put in any stent. So the importance of young myocardial infarction is two things. One is the etiology is different. The etiology is related to many times to smoking. The initial treatment is exactly the same, antiplatelets. We should rule out cocaine abuse. We could use out, you should rule out that they are smokers. You should quickly take these patients up for looking at how the coronaries look like. And an early primary treatment with the PCI is important. The issue of reperfusion is the same like oldest MI. But the important thing is, once you see a lot of clot, you can use mechanical reperfusion, and we can use suction, and we can use thrombolytic arteries into the coronaries. And this can clean up the vessels. And all you need sometimes is no stent, but just antiplatelet therapy and medical treatment. So this is important for us to understand, so that we don't put in metallic scaffolds in these patients for long and give them a lifelong of antiplatelet therapy. Many of them will not have too much of lipids into the plaque, and it's very important that you treat them a bit differently. The secondary prevention is still the same, antiplatelet therapy. If there's a lot of clot, we are now treating these patients with NOACs and warfarin. We use statins according to how their lipids are, and we continue statins if there is coronary artery disease seen. And the other traditional risk factor reduction of blood pressure, lifestyle is important. Smoking is extremely important to be stopped. If they are young diabetics, sugar control and lipids is an important thing. This risk factor reduction is extremely important for these patients, and stress and lifestyle change is extremely important. I'm also coming to this paper, which is just going to come in the Journal of the American College of Cardiology, which is basically going to come in the August version of the JACC, which is a genomic worldwide polygenic scoring in South Asians of Indian origin. So this is of Indian data. And what is extremely important is that the young myocardial infarction patients seem to have the highest risk in terms of the polygenic risk score in the South Asian group of patients. So in conclusion, what I would like to say is that in the group and subgroup analysis of the Tamil Nadu STEMI program, we found that about 24% of STEMI patients were young, and they were less than 45 years of age, which is very unusual and not usually projected or shown in many of the literature worldwide. Smoking is the main risk factors, and the prevalence of diabetes and hypertension and hyperlipidemia is significantly lesser than in the older population. I think they have a better prognosis than older MI, but you need to be very important that they stop smoking and do their risk reduction so that they prevent further events. The most important thing is that plaque erosion is a different pathology in these patients rather than plaque rupture. And a prothrombotic milieu of increased clotting in the arteries can create STEMI in these patients, and these are being further explored. We are very interested in this data genetic analysis of these polygenic risk scores in these young patients, which may predict the chance of developing STEMI much more than even familial hyperlipidemia. Thank you very much for your patience here.